Okay, so we can continue with our reading. Who would like to start? Okay, I someone raised her hand. Shamalota Dvidasi. Thank you.
Thank you, Hare Krishna.
Hare Krishna.
Chapter 6, Pain Management and the Use of Allopathic Medicine. The fundamental understanding when assessing pain is to accept that the patient's self-report is the most reliable indicator of the intensity of his own pain. Accordingly to Margot McCaffrey, RN, MS, and pain management specialist, pain is whatever the experiencing person says it is, existing whenever he says it does. Pain is subjective, influenced by one's childhood, life experiences, and culture. A patient, I'm having a little bit difficult seeing. A patient perception and reaction to pain is also influenced by mood, morale, and pain threshold. Therefore, observations of a patient's behavior should never override what the patient is describing. Similarly, sleep obsedation should never be mistaken for pain relief. Someone with severe pain can fall asleep. Let's see. I'm having hard time moving down. Someone with severe pain can fall asleep simply by exhaustion, but may later awaken in agony. Some patients hesitate to admit they are in pain or even deny they are experiencing pain at all. This can occur for many reasons. Some terminally ill patients fear they will become addicted to pain medicine if taken on a regular basis. Family members often believe this is as well and reinforce the patient's belief. Some fear the side effects associated with pain medications. Others see it as a weakness to admit they are in pain or simply feel they will become a burden to the caregiver if they complain. In addition, some patients fear they will not be alert and clear thinking if they succumb to taking medicines for pain. Pain medications, if given correctly, can give the suffering patient relief without the side effect of extreme sedation. There is a saying among hospice professionals regarding pain management: start low, go slow. This is discussed in more depth throughout this chapter. Whatever the reason, the caregiver should encourage the patient to verbalize her discomfort in order to achieve relief. As the caregiver, reassure the patient that medication correctly taken for pain relief is rarely psychologically addicting and that any possible side effects, such as nausea or constipation, can usually be relieved. Explain to your patient that complaints of pain will never be seen as troublesome or as a sign of weakness. Tell him that you are there to ease his discomfort in any way possible. Inevitably, a patient's condition will worsen,
Take
making it
note,
difficult or even
maybe next
impossible
week.
for him to verbalize
Yeah.
his pain. The caregiver should assume that if the patient's disease caused pain when he was alert, then his disease process is still causing pain even though he is unable to express it. At this point, a caregiver should watch for subtle signs of pain, such as frowning, facial grimacing, especially when being repositioned, moaning, and rapid breathing, and um, heartbeating and heartbeat. Even when these signs are not present, pain medication should be continued round the clock to achieve a therapeutic blood level for comfort. This will ensure that the patient's final days are as peaceful and pain-free as possible.
Thank you so much. Would
Thank you.
anyone else like to continue? Oh, we have Aradhana Devidasi. Thank you.
Hare Krishna, everyone. Hare Krishna devotees. Please accept my humble obeisances. All glories to Srila Prabhupada. Pain assessment. When assessing a patient's pain, hospice staff will often consider its location, onset, character, intensity, frequency, and duration. A terminally ill patient will often have different types of pain in several locations. However, not all complaints of pain may be disease-related. For example, a patient might complain of general soreness that may be caused from being bedridden and immobile. To accurately assess a patient's pain, it is best to ask the following questions. Where is the pain? When did it start? What type of pain is it? Is it dull, throbbing, stabbing, aching, or burning? This will give clues as to the source of the pain, such as bone, visceral, nerve, or muscle. For example, nerve pain tends to feel like an intense burning or tingling pain, while bone pain may feel like a throbbing or aching pain. Allow the patient to describe the pain in his own words. What is the intensity of the pain? Is it mild, discomforting, distressing, excruciating? A commonly used pain rating scale is the 0 to 10 pain scale. You can implement the 0 to 10 pain scale by first explaining that 0 means no pain and 10 is the most unbearable pain ever experienced. Ask the patient to rate her pain between 0 and 10. Visualizing the pain scale sometimes assists the patient to better assess her degree of discomfort. You can make a 0 to 10 pain rating scale by drawing a horizontal line on a piece of paper. Write a 0 on one end and a 10 on the opposite end. Fill in the numbers in between. The 1 to 4 range is considered to be mild pain. The 5 to 6 range is moderate pain, and the 7 to 10 range is severe pain. However, one patient may be able to tolerate pain in the 6 or 7 range, for example, while another patient may need pain relief to a 1 to 2, to a 1 or 2 in order to be comfortable. Again, pain is subjective and individualized. How long does the pain last? Is it sporadic? Is it constant? Does the pain feel worse at a specific time of day? What makes the pain worse? Sitting, standing, walking? Does anything help to relieve the pain? Has there been a change in the pain since yesterday or this morning? Although it is the goal, zero pain relief is not always possible with a terminal illness. McCaffrey suggests satisfactory pain relief is a level of pain that is noticeable but not distressing, and one that enables the patient to sleep, eat, and perform other required or desired physical activities. Constant reassessment of the patient's pain is essential. Terminal pain can intensify and new pain can develop, sometimes daily. Inappropriate assessment of a patient's pain can result in ineffective treatment and unnecessary suffering. Did you want me to continue or
Oh, thank you.
somebody else?
Thank you so much, Aradhana. Does
Hare
anyone
Krishna.
else would like to continue? No? Aradana, would you like to continue reading a little?
Sure, sure.
Thank you so much.
A word about choices. Some patients may desire a more alternative approach to their pain management rather than agree to the use of allopathic medicine. However, having been trained as a nurse in a more conventional setting in the West, my education and expertise in pain management involves allopathic medications. I have seen them work. I have seen that when given correctly, they diminish excruciating pain in patients about to die, making their last days comfortable ones. I have also seen a few patients experience intolerable side effects to these medications. Most of the common side effects that can occur with the use of allopathic medicine can be easily controlled. Certainly, the reader is invited to explore other other types of therapies for pain management. However, it is never recommended to administer medicine of any kind without the proper guidance of a healthcare professional. The patient's physician, as well as any hospice staff involved in the patient's care, should be consulted before trying any alternative or over-the-counter medication. Even some herbs can have adverse effects, especially when taken with certain medications. The main concern should be keeping your patient as pain-free as possible with as few side effects as possible. Chapter 9 addresses complementary therapies that may be helpful for symptom management in a hospice setting. Most hospices in the West have guidelines similar to the pain management principles stated in this chapter. Even when a patient is receiving hospice care, however, he has the right to refuse a medication and/or discuss any apprehension related to the medication recommended by the hospice staff.
Thank you so much, Aradana. Would anyone else like to continue? Karuna Purnashakti Devidasi, thank you.
Three major analgesic groups: non-opioid, opioid, and co-analgesics. Non-opioids. In general, non-opioid medications consist of acetaminophen, aspirin, and non-steroidal anti-inflammatory drugs, NSAIDs. NSAIDs work on the peripheral nervous system, the portion of the nervous system outside the central nervous system, which consists of the brain and spinal cord. They work at the site of injury and are usually given for mild pain as an anti-inflammatory or as an antipyretic fever reducer. Many non-opioids can be purchased over the counter without a prescription, such as acetaminophen, e.g. Tylenol, aspirin, ibuprofen, e.g. Advil, Motrin, or Nuprin, and naproxen sodium, e.g. Aleve. Acetaminophen is also known as paracetamol in some countries. Examples of NSAIDs requiring a physician's prescription include ketorolac, tromethamine, Toradol, indomethacin, Indrocin, nebumetone, Relafin, and choline magnesium trilysate. As with most medications, NSAIDs have a ceiling dose when used daily. Do not take more of this medication than is recommended. An overdose of ibuprofen can cause damage to your stomach or intestines. The maximum amount of ibuprofen usually recommended for adults is 800 milligrams per dose, or 3,200 milligrams per day, 4 maximum doses within 24 hours. Use only the smallest amount of ibuprofen needed to get relief from your pain, fever, or swelling. Over-the-counter tablets of ibuprofen generally contain 200 milligrams, but a prescription dose can contain up to 800 milligrams per tablet. This medication should never be taken on an empty stomach. It is recommended that ibuprofen be taken with food or milk to prevent stomach upset. Therefore, to avoid toxicity, it is necessary to keep careful records of when and how much of the medication is given. Possible side effects of ibuprofen, as well as some other NSAIDs, include, but are not limited to, dizziness, headache, nervousness, peripheral edema, swelling in the limbs, tinnitus, ringing in one or both ears, epigastric distress, nausea, stomach ulcers, diarrhea, constipation, prolonged bleeding time, itching, and rash. Acute renal failure is less common, but can be a life-threatening side effect. NSAIDs should always be taken with food and never on an empty stomach. Over-the-counter NSAIDs should never be administered to a patient without consulting a physician or hospice nurse because of possible adverse interactions with other medications. In addition, if one NSAID is ineffective in treating a patient's discomfort, trying another type of NSAID may prove to be more effective. Aspirin, although an excellent analgesic for mild pain, has a high incidence of stomach irritation. It should always be taken with milk, food, a large glass of water, or an antacid to reduce gastrointestinal distress. It also works as an anti-inflammatory agent and as an antipyretic. Aspirin has a blood thinning effect, and many cardiac patients take aspirin in small daily doses for its anti-clotting factors. However, it is usually not recommended for a patient who is already taking a blood thinning medication or to a patient with impaired kidney or liver function, a history of gastric ulcers, or other bleeding disorders. Enteric-coated aspirin is less likely to cause gastrointestinal discomfort, but since enteric-coated as well as sustained-release tablets are more slowly absorbed, it is not suitable for fast relief of pain, fever, or inflammation. As with NSAIDs, it is best to consult your physician or hospice nurse before administering over-the-counter aspirin, since it does not interact well with many prescription and non-prescription medications. When using enteric-coated aspirin, it should never be broken, crushed, or chewed. Anyone else?
Thank you so much. Triti Kopika?
Yes.
Thank
Hare
you.
Krishna, everybody.
Hi.
Acetaminophen, example Tylenol, tend to be milder on the stomach than aspirin or other NSAIDs, but does not have the same anti-inflammatory effects. It is generally given for mild pain and to reduce fever. When a hospice patient is no longer able to swallow whole pills, acetaminophen may be given in other forms, such as liquid, chewable, or rectal suppositories. Unresponsive, unable to swallow any form of medications, and need relief from a fever. Side effects of acetaminophen are fewer than with NSAIDs and aspirin, but can include rash, jaundice, and liver damage from toxic doses. In a patient whose blood glucose levels are being monitored with a home monitoring system, acetaminophen can sometimes produce false positive decreases in blood glucose levels. Generally, when used as a long-term therapy, acetaminophen dosage should not exceed 2,000 milligrams daily, or the patient will run the risk of toxicity. Opioids. Opioid is a preferred term to use for narcotic medication. Opioids are non-opium derived synthetic drugs used for moderate to severe pain. Opioids work by attaching themselves to specific opiate receptors on cells in the central nervous system, brain, and spinal cord. An important intervention in pain management for mild to severe pain is to anticipate and prevent pain rather than treating it as it occurs. Waiting for pain to reappear before administering the next dose of pain medication is futile and only serves to place the patient in a never-ending cycle of anguish and relief. This is why it is so important to administer round-the-clock dosages, that is, given at set times throughout the day. No one should have to wait until he is writhing in pain before receiving medication for relief. Once pain occurs, it is more difficult to control. Anticipation on the part of the caregiver is the key to successful pain management. A patient's suffering only heightens when combined with the anxious expectation of oncoming pain. Once the patient's pain is controlled using the round-the-clock administration method, she becomes pain-free, or as close to pain-free as possible. She is then maintained on a steady dose of medication until the disease process exacerbates and the dose must again be increased for comfort. Hare Krishna.
Hare Krishna, thank you so much. Would anyone else like to continue? Oh, I can continue then. Weak to moderate opioids. Some opioids are effective for mild to moderate pain, such as oxycodone, e.g. Percocet, or hydrocodone, e.g. Lortab or Vicodin. Many of these medications come in combination form and may contain acetaminophen or aspirin. Percocet, for example, contains acetaminophen. In many cases, the acetaminophen or aspirin helps to give greater pain relief than if the opioid were used alone, or even in combination. These weaker opioids have less analgesic effect than morphine or other more potent opioids. Care must be taken not to exceed the prescribed dose of these combination medicines, not only for the detrimental effects of receiving too much of the opioid, but because toxic levels of acetaminophen and aspirin can be equally dangerous. Side effects of opioids vary according to the specific medication, but some adverse effects of these weak to intermediate medications may include, but are not limited to, dizziness, sedation, nausea, vomiting, constipation, rash, itching, headache, dry mouth, abdominal discomfort, and respiratory depression. The goal of using any opioid is for the patient to be as pain-free as possible without sedation. The patient should be able to relate to his environment without feeling euphoric. Because nausea and constipation are common side effects of opioids, it is suggested that whenever any type of opioid is started, laxatives, stool softeners such as Sina, G. Senocot, or docusate sodium, G. Colas, be given regular. Sorry.
No, I was going to say colace.
Oh, Colas. Okay, thank you.
Yeah. It's
Be
okay.
given regularly to avoid constipation. Never wait until the patient is constipated to begin use of a laxative, stool softener. Along with laxative or stool softener, an antiemetic medication should be given on an as needed basis for nausea. It is recommended to have on hand an antiemetic.
Antiemetic, that means an anti-nausea or vomiting medicine for as needed. Because if you take a pain medicine like an opioid, then a lot of times it'll make you nauseous. So you want to have something on hand for, it's called an antiemetic, in case it makes you nauseous. So you'll have it in the home in case your patient needs it. Does that make sense?
Yes, it makes complete sense.
Okay, thank you.
Thank you. Antiemetic that comes in suppository form in case the patient cannot tolerate it in pill form. As of November 2010, the U.S. Food and Drug Administration, FDA, asked the pharmaceutical company that makes the prescription pain medications Darbon, genetic name Proxifene, and Darboset Proxifene with acetaminophen, to withdraw the drugs from the U.S. market. The FDA says that the drug propoxyphene puts patients at risk of potentially serious or fatal heart rhythm abnormalities. The medication is usually given for mild to moderate pain. The director of the FDA's Office of Surveillance and Epidemiology stated, "We recommend to physicians to stop prescribing the drugs. As for patients, do not stop taking it, but we urge you to contact your healthcare professional. Do not delay. The drug's effectiveness is reducing pain. Reducing pain is no longer enough to outweigh the drug's serious potential heart risks."
Can I just say you did an amazing job reading those drugs names? That was amazing.
Thank you so much.
It's not
You're so
easy.
sweet. Thank you. Yeah, I've never seen them before, especially.
I know. That's amazing. That's
Thank you.
amazing. What I
Thank you
wanted
so
to
much.
say, you're welcome. You really did a great job. I want to say to everybody, this chapter is very confusing sometimes. Okay. So what I want to say is just know that this information is here. So when you're taking care of someone, your family member, a friend, a devotee in your community, this is a good resource. Okay, I've had devotees actually say to me they were dying. Okay, I remember one in Alacho I went down to see, and she said to me, "I'm using this chapter as my drug manual. I'm looking up every medication that my hospice nurse is giving me, and this is a great resource because I can look it up in this chapter, and I'm finding it, and I'm seeing what it does and the side effects and all this. So just know that this information is here, and you can also look it up online, obviously, but it's a good resource. So it's easy to look up, and the more you use allopathic medicines in hospice care, the more you'll become familiar with them. And I've had so many devotees say to me, "I would never take allopathic meds for pain, never." Okay, and there was one very elderly devotee woman who said that to me. And, and I said, why wouldn't you? If you were, let's say you have cancer and you were in pain, why wouldn't you take something for pain that's allopathic? Because I can guarantee you, if you had cancer of the bone, which is considered the worst pain that you can have when you have cancer, out of every type of cancer, bone cancer is considered the worst for pain. And she said to me, because it's toxic. Okay. And I said, but Mataji, so is cancer. Cancer is toxic. Okay. It's destroying your body everywhere. Okay. And she said, yes, that's true, but I would never take it. I said, I'm sorry, but herbal tea is not going to take your pain away. All right. Herbal tea, some kind of, supplements that you find at the, Whole Foods, health food stores. It's not going to take your pain away. I wish it did. I really wish it would, but it's not. It's proven it's not going to take it away. If it did, oh my God, I'd be doing the happy dance in your bedroom, but it's not going to take it away. You can try it at first and see what it does. But if it doesn't take it away, you might be forced to take something stronger. So don't you know? I mean, it was almost It was so weird. It was so Krishna. Couple years later, she's living in Vrindavan half the year, and she calls me and says, I have cancer, unfortunately. And she flew back to America, to the city where I live. And first thing she did was have her daughter call me and say, my mom's got cancer, as you heard, and she's back in the city here. And she wants to know what she can take for pain, including allopathic pain medicine. And she was dead set against it, no pun intended, but she really did not ever take even an aspirin for a headache. She would drink herbal tea or something like that. And she would take now anything to take the edge off of her cancer pain. So I've had this experience with devotees over and over and over again who would never take something allopathic, not even an aspirin or acetaminophen or paracetamol or whatever country you're in, it's a mild over the counter, uh, very mild pain medicine that you take usually for a headache. And they wouldn't even take that until they got some very awful terminal illness like cancer that had spread all over their body, and they really needed something strong for the pain. So they were willing to take any kind of allopathic medicine. So I've learned over the decades doing this that most of the time, 99.9% of the time, when a devotee tells me I will never, ever take an allopathic pain medicine, never. They usually change their mind when they're faced with the situation and the severe pain that goes along with that illness. So just telling you my experience. It could be different with your experiences in the future, but that's what I've experienced. Okay. And so I don't know if it's what does everybody think? Should we go through this chapter, or is it just good enough for you to know that the information's here and let's move on to the next chapter? It's up to you guys. The one thing I want to really stress before we do move on, if that's what you want to do, is the 0 to 10 pain scale. You can go online, you can Google 0 to 10 pain scale, and you can print out so many of them. Usually the one that's used, and you can print it out. Pharmaceutical companies will send you one. It's usually made out of like a plastic coated cardboard, and you can carry it in your pocket. Ladies, you can carry it in your purse. I mean, it's just a small little thing, like, you know, uh maybe 6 inches, 8 inches long, and it has 0 to 10 with little lines. Okay, and that's for people who are either elderly, have dementia or Alzheimer's, um, people who, let's see, children. It's good for children who can't read 0 to 10. They can just point to the faces. The faces start out 0 pain is no pain at all, obviously. So it'll have a happy face. And then as the numbers progress from 1 to 0 to 3 is no pain. 4 to 4 and 5 would be moderate pain. Okay, and 6, I'm sorry, so more, 4 to 4 or 5, uh, that is 4 to 6, I would say would be moderate pain. 7 to 10, severe pain. Okay, so they would just point to the number, or if it's a child or an elderly person, or someone with dementia, tell them point to the faces. If you have no pain or very little pain, you can point to the happy faces. It starts out smiley face, and then it goes to, little bit of sad face, and number 10 is like your hysterically crying face. So they just point to how they're feeling. Okay, so that's the 0 to 10 scale, and that's a very common scale that they use in hospitals and hospices in the West. Okay, I brought them to India when Giri Raswamy and I built the Bhaktivedanta Hospice in Vrindavan, and I trained the staff how to use them. I'm hoping they still use them. It's a very commonly used scale, and they're good to know, it's good to have. So I'm saying go to Google it and print them out, or you can, draw 0 to 10, on a piece of paper and teach the patients how to use them. They're very handy to have. Okay. So that's a really good thing to know out of this chapter. It's a really good one to have. And if you want to look up these medications, that's a good thing to do. And also another great point in this chapter for you to learn is the let me show you what page. I'll tell you what page. Is the World Health Organization, WHO, okay, WHO, the WHO commonly used, not a scale, but more like what the World Health Organization teaches. Okay. And it's on page 98 in that chapter. The World Health Organization 3-step analgesic ladder for pain control. And this is used all over the world, obviously, the World Health Organization. I taught them this at the Bhaktivedanta Hospital in Mumbai, and I taught the staff this at the Bhaktivedanta Hospital in Vrindavan. And the World Health Organization breaks the pain management down to a 4-component medication system to treat severe chronic pain and terminal pain. Okay, so if you look on page 99, if you're looking in your book, and Rasika, if we could turn to that on the screen. Okay. Is everybody hearing me okay? Just turn to page 99.
Yes, we can hear you. Okay.
Okay, and number 1, an extended release opioid given round the clock. So there's a 4-parter, I should say, to pain management. So number 1 is a patient is given an extended release opioid, okay, of strong medicine, when they get to this point. Okay, so they're given round the clock. So that usually means every 12 hours. So let's say they need a very strong medicine. So if you're given it, let's say 8 in the morning, and then you get it again at 8 p.m. at night. So it lasts about 12 hours, and you're given it every 12 hours. So twice a day. Okay. And then what if, like, after 10 hours, the patient's in pain? What do you do? Well, you're not due the second dose for the day until 8 tonight. So you're not going to let them writhe in pain in the bed for another 2 hours until it's due. So they need something for what's called breakthrough pain. Okay, it's 10 hours. They're not due for that medicine another 2 hours. So what do you give them? Let's say they're on, not everybody gets morphine. That's a myth in hospice. Not everyone gets morphine. I'm allergic to morphine, so they could never give it to me. So there's other kinds. Let's say Dilaudid, hydromorphone, it's called. Okay, so let's say they can take that. I'm allergic to that too. So let's say they can take that medication. So you give them that every 12 hours in a pill or suppository if they can't swallow any longer. And then in between, they need something for breakthrough pain. So you would give them a couple of drops of this liquid medicine. Okay, hydromorphone comes in a liquid in a little bottle with a dropper. And you would put a few drops underneath their tongue or at the inside of their mouth. It's called buccal. buccal dose, right? So it would kind of absorb through the inside of their mouth. So you put a couple of drops under their tongue, which is sublingual, under their tongue, or you would put a few drops in the inside of their mouth, like so that it would absorb like on the inside. Okay, so that would be like in between the every 12-hour dose. So it's as needed. The patient would say to the nurse, or they would say to the caregiver or family member, I'm having a lot of pain. My pill isn't due until, 2 more hours. What am I going to do? I'm really having pain. So you give them the drops. Okay. And that ties them over until they're ready for their 12-hour dose. Okay. And then in between, like we read, every day, they would get a laxative and a stool softener. Why? Because what we read, a side effect of these strong pain medicines gives you what? Gives you constipation. And it's a very uncomfortable side effect. So you're going to have to give them a laxative / stool softener every day or every other day, depending on how bad that side effect is for them. Okay. And then what's the fourth one on page 99? An antiemetic. And our wonderful reader just now, she read antiemetic, which is as needed for nausea or vomiting, because a lot of people get that side effect with an opioid, with a very strong pain medicine. So that's basically the World Health Organization's plan for people, especially who are on hospice or chronically ill and have a very painful disease. Okay, so that's the sum and substance of this chapter. It's one of the longest chapters in the book. I want to save you from, reading every detail, but on your own time, when when you want to read all of the details, then please go back and read this chapter. But just know that that's what's involved in this chapter. So when you are taking care of patients, then you'll be able to look back at this chapter and see all the medications that are usually used in hospice for pain management. Does that make everything a little clearer? I know for the nurses in this group and any other kinds of medical personnel, that it's not as difficult, but for those that aren't in the healthcare field, this chapter can be a little confusing. So I just wanted to give you a kind of a, you know, um, description that's not as confusing. Okay,
Yes, thank
makes
you so
sense?
much. Yes, it was very clear.
Okay,
you so
so
much.
what does everybody want to do? Should we go back and finish this chapter, or do you want to just kind of skim it on your own? Anybody have an opinion?
I think you explained it very clearly. So if everyone agrees, maybe we can move on to the next
Okay.
chapter.
Okay, and then there's, if you can see at the end of this chapter, there's a chart, which I've tried to make it really simple for you guys. So there's non-opioids, there's opioids, there's different kinds of pain, like you'll see on page, I don't know what page it is. It's at the end of the chapter. So you'll see this chart, and there's types of pain, co-analgesics it's called. So it's medicine that you give along with your pain medicine. So there's nerve pain, there's bone pain, which I remember I said that's one of the most difficult to treat. Okay. There's when I took care of Dr. Tirtha Swami, he had a great deal of bone pain, and we tried to deal with it the best we could. Gastric distension pain, that's also not as hard, but there's some suggestions on this chart of what you would do for that. There's rectal or bladder spasms. Bladder pain, when somebody has bladder cancer, very, very painful. I explain in the book how I had one patient in a hospice I worked in, and she was in so much agony from her bladder cancer, because usually with bladder cancer, the bladder spasms. If you can imagine somebody squeezing your bladder from inside. And it just was so painful that she didn't know what to do. She was an older lady, and she kept trying to get her leg over the bed rail at the hospice. You know how the hospital bed, how it has the bed rails up. And she was in agony. So she would put her legs over the rail and try to just get away from the pain by climbing over. She just wanted to climb out of the bed, basically, and just run away from the pain. That's how painful bladder cancer can be. So, there's just there's over 200 types of cancer, as I've said, and each one feels differently. And bladder cancer is just filled with spasms that just don't end unless you have the proper medicine. And believe it or not, we tried giving her morphine and it didn't even touch that pain. And it's one of the strongest pain medicines there it is, and it didn't help her at all. So we gave her something called B&O suppositories. It stands for belladonna and opium. And I don't even know if they make it anymore. This was decades ago. And it was the only thing that touched her pain. So we had to have a special pharmacist who made them. And there was only one in the city where I lived out west. And he made it up special just for her. He made them. And it did help her pain. And she wasn't trying to climb out of the bed and to run away from the pain anymore. So, sometimes in hospice, we come across somebody with that much pain, and we have to become very creative. But, all this isn't going to be on you. All this will be on the hospice staff. But you will be the communicator between the patient and the hospice staff sometimes. So you're going to have to call the staff and say, he or she is in so much pain. They're trying to climb out of bed to get away from the pain. What do I do? Can you please come over and assess her again and, get her on something stronger so they can be comfortable? So always remember that as a caregiver to the patient, you're the eyes and the ears of the nurse, because you're going to be there with the patient a lot more than they're going to be, because they don't come every day usually until the very end. So you're the eyes and the ears. Okay, so if the pain increases, if the pain is not under control with what they have the patient on, you're going to have to be the communicator. Okay, all right. I hope that makes sense. Okay, and
Oh,
doesn't
yeah, it
feel,
was so clear. Thank you so much for sharing
yeah.
this very important information and
Oh,
for
you're welcome.
explaining this chapter
And
very clear.
I just don't want it to be overwhelming to anyone, you know. I don't want you to feel overwhelmed. It's just a matter of being observant of what the patient's experiencing, and being the communicator with the hospice staff. Okay? All right. And I just noticed the time. I'm sorry, I'm keeping you late.
No, it's fine. Thank you so much. It was necessary.
Oh,
So
thanks.
next session we can start with the next chapter, which will be
Yes.
chapter 7. So please everyone join us again next session next Sunday. Thank you so much everyone for being here. We were so happy to be here reading this very important chapter together and for participating too. Thank you so much to Mother Sangita for being here too. And see
Oh,
you.
thank you to everybody that came. I'm so sorry I kept you a few minutes later. I'm really sorry. But that's one of the most important chapters in the book. We have to keep the devotees and others comfortable when they're facing end of life. That's the most important thing. Plus, because really we want to keep them spiritually uh, comfortable We want to keep them focused on spiritual life, and they can hardly do that when they're in pain. That's why pain management is so crucial. Okay.
Thank you so
Okay.
much.
Hare
Thank you,
Krishna.
everyone. Hare
Thank
Krishna.
you.
Thank you.
Haribol.
Haribol.
Have a wonderful week.
Thank you.
Thank you.
You
Hare Krishna,
Hare
everyone.
Krishna.